parts of the world. So there have to be parallel studies on how do you, treat the vast burden of IBD that's not in North America and Europe. And there's just not as much focus there. But maybe if you get early treatment, you can pull it back after 6 months, and then you've achieved the same outcomes without continuing it lifelong. So generally, we don't de-escalate treatment unless patients really want to. It's not the default to de-escalate unless somebody. But if somebody wants to de-escalate, then I make sure they're in endoscopic remission, and if they are, then I would stop the biologic and monitor with the fecal calprotectin every 3 months and see if it starts to go up. Then I would have them go back on treatment.
Do you switch them from adalimumab to Vido just to make sure that the spacing of the injection happens? Now, supposing somebody is on adalimumab once in 2 weeks, say once they have achieved a good remission, do you change out to Vido?
So, I mean, as you said, these are lifelong diseases. We don't want to lose options. So I almost never have people switch drugs that are working for them, because you never know if the next drug is going to work for you. So it never makes sense to me to switch just based on safety, because there are many patients who've switched and then the new mechanism is just not effective, and then you go back to the first mechanism and it's not working anymore. So I would never electively switch.
Okay.
Thank you so much, sir. Now, before we invite Dr. B.S. Ramakrishna to do the panel discussion on the current issues on IBD, I have a very pleasant task today to bring to the stage here in front a very young gastroenterologist by name Dr. Raghuram, who is 80 years old. We invite Dr. Ahmed Ali to present a bouquet to Dr. Raghuram. His birthday actually is on the 7th, but very, very happy birthday to you, sir. Very, very happy birthday to you, sir. Now let's have the panel discussion. Dr. B.S. Ramakrishna will be the moderator. And in the panel, we have Dr. Ashwin, Dr. Devendra Desai, Dr. Malati, and Dr. Gautam Krishnamurthy. May I invite the panelists to the stage, please?
Good evening, everybody. So it's great to be here to have on the panel Dr. Ashwin Ananthakrishnan, who is director of the Crohn's and Colitis Center at the Massachusetts General Hospital in Boston, which has been a mecca of IBD research for a long time. And to have Dr. Devendra Desai from the Hinduja Hospital in Mumbai. Also on the panel here we have Dr. Malati Sathyasekharan, who's had a very long-standing interest in IBD, both adult and pediatric, I think. And Dr. Gautam Krishnamurthy, who is a surgeon, surgical gastroenterologist from the institute that I work in now, which is SIMS. So we'll use this panel discussion basically to look at some of these issues which already were brought up, and I think Malati has preempted me in some of the discussions about the diet, but that's okay. And the idea was to have discussions on these. And then there's the issue of a Western perspective versus an Eastern perspective. And I'm hoping that Dr. Ashwin is going to give us the Western perspective on this. So here we have a case history that is just basically based on a case of Crohn's disease. And this is a 24-year-old lady who presented to us in 2016, 6 years ago, with abdominal pain. And this is a real life case. So, abdominal pain, loose motions, and weight loss. Colonoscopy showed ileal ulceration with a deformed ileocecal valve. The biopsy showed large confluent granulomas. Interestingly, she had a very strong family history of Crohn's disease. Her younger sister, her paternal aunt, and her paternal uncle all had Crohn's disease. So we said, yes, this is Crohn's disease. Maybe I should ask Malati, what's the significance of the strong family history? Because she's been interested, and she's had a lot of people that she's been treating since the time they were kids.
Yeah, I think this family history has been given a lot of importance in IBD because as Dr. Ashwin was also saying, there is a genetic role in that Venn diagram we've always been drawing and family history, but in the questionnaire which we put, we did not get that high. Maximum we got was 20 to 25% saying that yes, there was a member in their family. Though theoretically we do say, but if there are twins, then it is more important, especially if they are monogenic twins. But family history, 20 to 25% is what we got from our question.
So I'll want any other member of the panel can also jump in. Ashwin, if you have something to comment.
Sure. I mean, we've looked at this in our registry where we had about 1,000 patients with Crohn's, and we specifically looked at whether having a family history meant you had a higher genetic burden and so more severe disease and you were more refractory. And we actually didn't find that. The only influence of family history was an age at diagnosis, that people with a family history were likely to be diagnosed earlier. But there was a lot of dissimilarity in how the disease behaves. One family member could be mild, another could be severe. One could respond to one therapy and others to something else. So it doesn't directly influence it.
Would you think a strong family history makes it more likely that it's a monogenic problem?
I mean, if it's multiple members diagnosed at a very young age, then maybe.
Then it's more.
At 24, I don't know.
Monogenic IBD, we've got and we've given that as an important clue itself in the mnemonic. It matters, definitely it matters. A high family history, you get it in the previous sibling, you can easily make out like IL-10 and all that, you definitely get it. So I think monogenic, you will get it more closer because genetic influence is much higher.
So again, here we have this issue. Here's a young lady presenting for the first time, she's treatment naive, with ileal Crohn's disease, which by the looks of it, we would have to say that it is not penetrating or obstructing. How would you treat this patient? Would you start from the top down? I mean, 6 years ago in India, admittedly, we are still way behind the West in terms of biologics, so probably we're still 20 years behind. Would you do step up? And any of you that wants to comment, and would you do surgery?
So can we go back to the last slide, sir?
Mm-hmm.
Previous slide.
Yeah.
So this is a young patient. So basically what I am trying to do is whether this patient at a high risk of progression of the disease. So this is 24, one factor that this is young. We have probably ileal ulceration, so we don't know whether this is extensive disease, but probably localized disease. And patient probably is non-smoker. So we don't have many factors which tell us that this patient is a high risk for progression of the disease. So I would like to start with the step-up therapy in this patient.
That's a very rational way of doing it. I'm sure most of us in the audience here will definitely do that.
I was just a little concerned about that large confluent granulomas.
Yes. I was waiting for somebody to pick up on that.
Large confluent granulomas, for me, is it TB? Because rarely do we get such large confluent granulomas in Crohn's, classical Crohn's. But if I get this, I would like it to be TB.
So, yes, certainly. So in this case, it turned out that it was negative. But yes, we certainly wish to make sure that we are not missing TB here.